Hey guys, it's Dr. Sarah and Alicia here. We are excited to talk to you today about our top 10 questions that we get about early pregnancy. So, Dr. Sarah and I have an online health platform called She Found Health, and our mission is to get reliable, high quality information out to you guys. So, check out our website, www.shefoundhealth.ca. If this is the kind of content you're interested in, make sure you hit the subscribe button below and ding the bell so you get notified every time we release new videos. So, shall we get started?
Let's do it.
All right. Number one question we get in early pregnancy is, how do I know everything is going well? And so this is a kind of a tough question to answer. So there's a few things that we can do early on in pregnancy to help reassure you that things are going well. The first thing is when you're very early pregnant, we can do some blood work. It's called a beta HCG, or the pregnancy hormone. Before about 6 weeks of gestation, and that's from the first day of your last menstrual period, we check your hormones, and it should double every 48 to 72 hours. So for women who've had a previous miscarriage or who are worried about something, we can certainly do this to reassure ourselves that so far things are going well. We don't always do this in every pregnancy, but certainly if people have had challenging pregnancies before, this is something we offer just to help reassure us. The second thing that we can do is an ultrasound. And so this we usually do on most women to make sure that their dates are correct. We do this around 8 to 10 weeks of gestation. So again, from the first day of your last menstrual period. So this tells us that things are progressing normally and gives us the correct dates, which we then need to know for later on in pregnancy. And the third thing that you can do is pregnancy symptoms. Even though they can be really annoying, common pregnancy symptoms like breast tenderness, bloating, nausea and vomiting are all really positive pregnancy signs, and that extreme fatigue. So if you're experiencing these symptoms, you can generally be reassured that things are still progressing normally.
So the second question we get a lot is, when is it safe to tell people that I'm pregnant? And the big concern here is miscarriage. So most miscarriages or early pregnancy losses happen around the 7 to 8 week mark. And that usually presents as bleeding and cramping, but not always. And sometimes what happens is the pregnancy stops growing and you don't have any of those symptoms. And sometimes you don't find out until the 10 or 12 week mark. And sometimes what happens is we just can't hear the baby in the office and we send you for an ultrasound. So typically, what people often do is they'll wait until that 12-week or so mark, and they can be reassured that, they've made it to 12 weeks, everything's going well, and then they'll announce their pregnancy. We know that if you've seen a fetal heart rate on ultrasound, after the 12-week mark, the chances of a pregnancy loss go down significantly. So oftentimes people wait until that 12-week mark.
Yeah. Or heard the baby's heartbeat in the office, either one.
And then the other thing is some people often wait for the genetic testing. So we'll talk about that a bit later on, but genetic testing is offered for all pregnant women. Different testing is offered depending on your age, and that is looking for common abnormalities like chromosomal abnormalities, spinal tube defects, that type of thing. Typically the results get back later, sort of mid-second trimester, and some people wait until then to announce their pregnancy.
So the third question that we often don't get asked, but we know that women have, is how do I choose my care provider? And this is a really important piece because you need to find somebody who you connect with, who you trust, and who has your best interests in heart. In most communities, there's the possibility of 3 different providers we can choose from: midwives, family doctors who specialize in maternity care, or obstetricians. So in our community, the options are just between the first 2, midwives or family doctors, and our obstetricians are available to us for extra support, but they don't actually care for women from start to finish like we do. So midwifery care is a different model than family practice. Midwives go through a program that they get trained in normal, healthy pregnancy and newborn care. So they care for women from about 6 to 8 weeks of pregnancy through to about 8 weeks postpartum and their baby as well. And they're trained extensively in kind of the normal, typical pregnancy care. Their model of care, especially in BC, they're paid a little bit differently, so they are allowed more time to spend with you during your prenatal appointments. And traditionally, they used to provide one-to-one support in labor, so that would just be just your midwife and you in labor and not any nursing support. But now they're having more nursing support involved. They work in call groups sometimes, and sometimes they just work on their own. But those call groups tend to be a little bit smaller. So maybe about 3 midwives would share care for their patient or client population. So you may not get your midwife, but most likely you've met one of the midwives that will be attending your birth. So that's kind of the midwifery model of care. They also are funded to do home visits postpartum. So they can come to your house and do home visits as well.
And home births.
And home births. They
Mhm.
provide home births as well.
Mhm.
Sorry, that is a big piece that I missed out on. So that they've got the training to do home births, and they bring the equipment to your home to do that. So that is kind of the midwifery model of care. The family doctors, who we are, we go through our medical training. So we're trained in all things medicine, and then we do extra training in maternity care as well. So we are able to care for a broader spectrum of pregnancies. We have the training to do more complicated pregnancies than the midwifery model of care. And we're able to care for the things that are not pregnancy related. So hypothyroidism or bladder infections or pneumonias, all those types of things as well. So a little bit more comprehensive knowledge base in all things medicine, not just the maternity piece of it.
And I would also add, we do a lot of mental health.
Yes.
Yeah.
Yes.
So people who have underlying, significant depression or anxiety, we can co-manage that throughout the pregnancy.
Yeah.
Because we've got a lot of training in mental health too.
Yeah, for sure. And Dr. Sarah has extra training in addictions.
Mhm.
So we generally have a little bit of a broader
Mhm.
range of skill sets than midwifery, which is trained in just normal pregnancy and newborn care. The other thing that our model of care is a bit different in that we're not funded to do those extra long visits. So generally speaking, the visits are a little bit shorter, but a little bit more frequent. And we tend to be able to manage things within that time frame. And certainly if certain women or populations need more time, we're able to spend that more time. So the mental health populations, etc. The third model of care is obstetricians. So obstetricians have done their 5 years of obstetrics and gynecology residency. So they are trained in the complexities of pregnancy and postpartum. So they have a much higher skill set than both midwifery and family practice. And they're also trained in operative deliveries. So vacuums, forceps, and cesarean sections. So that is their skill set. So in Victoria, they support us. They're in the hospital 24/7. And should we need any support with more complicated medical issues during pregnancy, we can access them as well. In some communities, they do care for all women, regardless of complexity, and they kind of manage throughout. Most of those communities, you'd start seeing an obstetrician around 20 weeks, and they'd follow you through delivery and postpartum, but they don't do newborn care. So obstetricians would need support through a pediatrician or a family doctor like ourselves to care for the newborns afterwards as well. So those are kind of the 3 big care groups. They all provide great care. We all follow the same guidelines. It's just kind of the model of care and kind of the delivery that you might look into. So if you're hoping for a home birth, then midwifery would be your best bet. If you're looking for that kind of comprehensive care that can care for you and your family, then family practice might be your best choice. And if you know you're going to need an operative delivery and you've done this before and you just really need that kind of extra special high complexity care, then obstetrics would be your pick.
So another question we get a lot is, what blood work do I need to get? And we do blood work at sort of set intervals throughout the pregnancy, but early pregnancy, I say you go to the lab, you get 1 poke, and you get a lot of blood taken. So basically how I describe it is that we test for anything that could impact the pregnancy. So we check your complete blood count, looking for your hemoglobin and your iron levels to make sure there's no signs of anemia. We check your thyroid, as thyroid hormone is really important for the fetal brain development. And we also check your blood type. So we want to know if you're A, B, O, or AB, and whether you have the Rh positive or negative. If you're curious to know your blood type, you can ask us, because most people actually don't know until they get pregnant. We also do some urine tests. We want to make sure that there's no bacteria growing in your urine that would need treatment. When you're not pregnant, we're not as concerned, but when you're pregnant, if you have bacteria, even if you have no symptoms, you do need to be treated. We check for a lot of infectious diseases, no matter what your risk factors are. So we screen for chlamydia and gonorrhea in the urine. And we also do blood tests looking for HIV, hepatitis C. We check if you've got hepatitis B, and we screen for syphilis as well. These are all diseases that can impact the pregnancy and impact the newborn care as well.
And also, if we do discover that you are positive, we can help reduce the risk of baby getting these diseases. And so that's the big reason why we check for them, is we want to reduce the risk of baby having any of these diseases. So super rare, but it can happen.
Exactly. We also check for immunity to see if you're immune to certain infections that again can impact the pregnancy. A common one being rubella, which is referred to as German measles, and then chickenpox, if you're not sure if you had chickenpox as well. Sometimes we'll do additional tests for parvovirus, which is also called fifth disease or slap cheek, which is a common childhood infection but can impact a pregnancy. And do we screen for anything else?
Sometimes based on certain people's history, we will.
Yeah, and I think that's most of them. And then we also offer genetic screening. So, I think we'll probably do a whole video about genetic screening because it's a huge topic. But basically, genetic screening is an option for any pregnant person. And what we offer depends on what your age is. So there's typically for low risk individuals, which is under age 35, it's just 2 sets of blood work to the mom, drawn around the 10-week and the 15-week mark. And that's looking for different factors that are secreted by the placenta that could indicate an abnormality with the pregnancy, like a chromosomal abnormality like Down syndrome. Not everyone chooses to do genetic screening. So that's a conversation we have, and there's lots of great resources that we refer our pregnant population to. So in a nutshell, that's the beginning blood work of pregnancy. And then we test for a few more things further on that we'll get to at another podcast.
And certainly if you're hoping to get your pregnancy right off to the best start you can, we've got a guide, preparing for pregnancy guide, but it's totally appropriate for the first trimester as well. So we'll link that in the show notes below. So if you're interested in learning how to make sure you've optimized your health going into pregnancy or during those early pregnancy stages, make sure you check out that download below. So number 5. The next big question is, when will I get an ultrasound? So we kind of talked a little bit about this before, but certainly we try to do a dating ultrasound on all women coming into pregnancy. So depending on when you come to see your provider the first time, they should really order an ultrasound if their community is capable of that. And resources are different in every community, so we're talking specifically about what we do here in Victoria. We order a dating ultrasound, and usually that's done between 8 to 10 weeks of gestation. So that's looking to make sure that your dates are correct and that so far everything seems to be progressing normally. Now, as you can imagine, babies are pretty small, so they can't get a lot of detail into baby's anatomy, but they do like to make sure if you're having 1, 2, 3, or 4 babies at a time. So that's the first ultrasound that we would get. The next regularly scheduled ultrasound would be that kind of anatomy scan. So that is usually around 20 weeks of gestation. And so this is a really detailed ultrasound looking at how your baby is developing, looking at the position of your placenta, whether it's over your cervix and placenta previa or whether it's well away. It looks at kind of the umbilical cord and making sure that all the vascular structure or veins and arteries in that look normal. And it's looking at the amniotic fluid. So this is kind of our big detailed ultrasound. And this is often when they can tell fetal gender. So if you're interested in knowing what you're having, you can certainly tell the ultrasound tech at the time of your ultrasound. In Victoria, they're not allowed saying anything, but they will put it in the report if they can tell. Occasionally during this ultrasound, because of baby's position or because of mom's habitus, they can't get a really good view at everything. And so sometimes we'll need to do another ultrasound a couple of weeks later just to get a better view of certain pieces. That's usually nothing worrisome, but they just like to make sure that they've looked at all the structures properly. And those are kind of the main ultrasounds we get. We monitor your pregnancy, so if you're measuring too big or too small, we might get another ultrasound, or if you go overdue at 41 weeks, we'll order another ultrasound, or if you've got certain risk factors, we'll do a little bit more monitoring. But for a normal, healthy pregnancy, it's usually the dating ultrasound and the anatomy scan, and those are your major ultrasounds in pregnancy.
So another common question we get is, when can I hear my baby's heartbeat in the office? And it varies a little bit, but typically by 12 weeks, we should absolutely hear it. If women have, minimal tissue over their abdomen, sometimes we can hear it earlier, as early as 8 to 10 weeks, but that's pretty uncommon. Absolutely by 12 weeks, we want to hear that in the office. And, it can be still tricky to hear, especially if your uterus is pointing backwards or you've got a really full bladder that's increasing that space between the ultrasound machine we use and hear baby's heartbeat. But typically 12 weeks, you should absolutely hear it.
And most of us, if we can't hear it by 12 weeks, if we haven't had a recent ultrasound, we'll order another ultrasound, or we'll get you back in a week and make sure that we listen to it then.
Yeah. And sometimes we'll just grab a colleague and say, hey, can you come here and try and listen? And then Dr. Power will come in and literally find the heartbeat within 5 seconds. And sometimes it happens. I always tell people, we've got a big pool of fluid and a tiny little peanut bouncing around in there. So it can be hard to track down sometimes.
Yeah. So our next question is, my symptoms suddenly went away. Does that mean I've miscarried? And this is a common question people have. So like we discussed before, we have these common pregnancy symptoms, which are very reassuring if we have them. But if you don't have them, it does not mean that your pregnancy is not progressing well. Now, we do have a video on kind of those common early pregnancy symptoms, so we'll link that below. So check that out if you have any of those symptoms and you're struggling with how to manage that. But certainly by about 10 to 12 weeks, a lot of pregnant women's symptoms actually decrease on their own. So many women, after they get through that first trimester, feel great or feel much better than they did before. And so that's when having that ultrasound, early ultrasound, or hearing baby's heartbeat in the office between 10 and 12 weeks can be super reassuring. Now, sometimes if you do have a dramatic decrease in your symptoms around 7, 8, 9 weeks, that can mean that your pregnancy is not progressing. So certainly if that's the case and you're worried about that, please let us know. We want to hear from you. And if we haven't had a recent ultrasound, we can always order another one. Or if you're kind of close to that 10-week mark, we can try to have a listen for baby in the office. And if we hear a fetal heart rate, fabulous.
Another really common question we get is, I'm having some spotting in my early pregnancy. Does that mean I'm miscarrying? And absolutely, it does not mean that. It can, but there's a lot of other things that can cause spotting. We do want to know about it, absolutely, but typically it's not a miscarriage. Women can have a little bit of spotting around implantation. So when that placenta is starting to actually implant into the wall, they can have it from the cervix itself can cause it. So your cervix, the tissues become sort of really fragile in pregnancy and bleed easily. That can be a common cause, as well as something that's called, oh my gosh, I'm
subchorionic hemorrhage. I could tell because this is Sarah's placenta.
Yeah, so that's when you get a little bleeding behind the placenta. We see this so often on early ultrasounds. And most often what happens is that by the 20-week mark, these pregnancies have progressed normally and it completely disappears. But that can be a cause of bleeding in early pregnancy. There's a few other common causes like ectopic pregnancy, which is more rare but still can happen, as well as miscarriage. So definitely you have bleeding in early pregnancy. We would want to bring you in, do an exam, and see if we can figure out what's causing it. Sometimes we never know, but the pregnancy continues to progress normally. Be reassured that we want to know about it, but it does not mean you're having a miscarriage.
We do get a little bit more concerned when you're talking about ectopic pregnancies is bleeding with pain. So whether that's bleeding with menstrual type cramps or bleeding with significant pain, we definitely want to hear about those. Okay. And so another common question is, why am I so bloated? I'm only 8 weeks pregnant and my belly is huge. So we actually did a podcast on this around kind of hormones in early pregnancy causing constipation. And we'll link to that. But certainly it is progesterone. So progestation, is a hormone that our body secretes to help support our early pregnancy. But it has a lot of other effects. So it causes bloating. It causes your GI tract, your bowels to slow down so they're not moving things through as well. And so we get bloated, we get burpy and gassy and all those things. Totally normal, totally common. But it is that progesterone hormone that is really important for early pregnancy, but can be really annoying in many other reasons.
And so that kind of leads into the last most common question we get is, I'm constipated, what can I do? Constipation is so common in pregnancy, and the cause is similar to the bloating. It's that progesterone. It stops that relaxes that smooth muscle, and things aren't just passing through as quickly. The other reason is that your blood volume increases substantially while you're pregnant, and if you're not drinking enough water, you're going to become really dehydrated. So your body's going to pull all that fluid out of your stools, leaving them harder and more difficult to pass. Constipation, super common, and we've got, like Alicia said, a whole podcast and video all about that, so we'll link to that. And our biggest advice is stay hydrated and eat high fiber fluids. Eat high fiber foods. And you know what? That's really going to help you with those constipation symptoms.
And I always like to make fun of Dr. Sarah's husband. He loves his Metamucil. He's like an 80-year-old man in a 40-year-old man's body and has his Metamucil every morning. But actually, I bet you he's not constipated. So get your Metamucil.
Yep.
Put it in a big glass of water.
Yep.
Now, when you're feeling nauseous in the morning, it might be a bit challenging. So maybe wait until you're feeling a little bit less nauseous if that is one of your symptoms. But certainly making sure walking, water, and fiber, really important. And if you're still struggling after that, ask your care provider. There's other suggestions we can make for you. So there you have it.
Top 10 questions. Hopefully we covered them all.
Yeah.
If you've got more, pop them in the comments below. We're always happy to put more content out for you guys that you think will be helpful.
And we'll make sure that we link that Preparing for Pregnancy guide, also great in that early pregnancy to optimize your health, below. And we'll make sure that we link to those other podcasts that are appropriate. So the early pregnancy symptoms and the kind of the constipation in a pregnancy podcast and video. So thanks so much for joining us. Again, if you like this content, make sure to hit the subscribe button below and have a great day.